Good. Okay. Yeah. Well, obviously, radiology of TB is a huge subject, but I'll just try and give you some ideas about the sort of likely patterns we can expect and useful investigations, hopefully. Let's start with chest X-ray. Obviously, that is still the mainstay of imaging of the lungs. It's the most commonly performed imaging procedure at this and probably most of the hospitals. It's quite a low radiation dose, equivalent to about 4 days background radiation. So it's a good test for anything from weight loss to itching to anything. Radiographers often come to me and say, look, the GP's asked for this for itching. What do you think? I said, yeah, do it. That's fine. Could be lymphoma or something. So, anyway, let's talk about TB. Primary infection, as you probably know, I don't know if we heard a bit about it this morning, is maybe a subclinical illness, may present with not much going on there. Patchy airspace consolidation, looks like a bacterial pneumonia very often, and heals often with a residual calcific density, known as the DOM focus. You often get associated lymph node enlargement in primary TB, and when these higher lymph nodes calcify, it's called the Ranke complex. Let's say it's commonly lymphadenopathy involved. You can get miliary disease as a primary infection, depending on the immune status, and look out for pleural effusions in the patient with otherwise nebulous sort of presentation. If there's a pleural effusion, may be the only clue that TB is going on. Primary infection often involves lower and middle lobes rather than apical. Just to show the calcific focus there. Lymphadenopathy of both eye in this case. Very often right paratracheal lymphadenopathy is a feature as well. 15% will have no abnormality on the chest X-ray. It's often indistinguishable, as I said, from bacterial pneumonitis. Cavitation is unusual in the primary infection. As I said, Ranke complex is just the gun focus plus calcified central lymph nodes. Secondary TB is more often what we see. It's more insidious and prolonged infection, called reactivation or secondary TB, post-primary. And this is a more common pattern, to say. Usually upper zones, usually posterior or apical segments of the upper lobes, or the apical segments of the lower lobes. And again, we can see different sort of patterns depending on whether the patient is immunocompetent or not. As I say, pleural effusion, much more common in the post-primary setting. 30 to 40% says here. We can see a pleural effusion in this case. Typical meniscus sign, patchy, ill-defined airspace shadowing. Thickening of the horizontal fissure in this case, probably related to the effusion. In children, it's less likely that they'll get a pleural effusion. Let's see, ill-defined nodular airspace shadowing. You can get cavitation, is obviously a good clue. You see some consolidation with a cavity. Come back to that in a minute. If there's an air fluid level within the cavity, that's tells us that it communicates with a bronchus, and therefore there's likely to be open TB. 33% of post-primary TB will have higher lymphadenopathy. So it's not quite as common. It's 1/3, not quite as common as in the primary. It can present with lobar consolidation, tuberculoma formation, which is like a mass-like lesion, so that could be confusing for neoplasm. That's common presentation. Miliary TB is the one we all hopefully will recognise. It's a diffuse nodular. It can be difficult to get your eye in on it at first, but when you do see it, you recognise there's just something not quite right. I apologise, the projector is not as bright as it could be, but I think you can appreciate there's lots of fine little nodules here throughout both lungs. Said to be about 1 to 3 millimeters in size, about the same size as millet seed, I think is why it's called miliary. It's due to hematogenous spread or primary TB in a immunocompromised host. Cavitation then. We can all hopefully recognize this one, not so difficult. Massive ring shape here with an air fluid level. So that tells us it's communicating with an airway and there's fluid within it. Sometimes they're a lot more subtle even than this, and it can sometimes be only appreciated on CT. But in this X-ray, we can see loss of volume in the upper lobe, diffuse sort of nodular airspace shadowing, also some abnormality over here. You can see a cavity here, possibly some cavitation on this side too. So that's an important sign to look out for. If we see a cavity which has been thin-walled previously, and then on repeat chest X-ray becomes thick-walled like this can be an important sign of reactivation. But obviously, other causes of thickening in a pre-existing thin-walled cavity can be a carcinoma or also aspergilloma. If it gets colonized with fungus, you can get initially just thickening of the wall before you get the typical fungus ball appearance. But always have other possibilities in the back of your mind. Here's just an example, CT through the apices here. This is the same patient. You see there's cavities over here, thin-walled. Not sure, it's difficult to see. This is in a sort of hidden review area behind the clavicle, very difficult to appreciate. There's a lot of overlapping shadows here. But when we did the CT, we could see that in fact one of these cavities does have a solid ball within it. This was a mycetoma or aspergilloma. Other examples. Again, this one shows the classical air present above a solid round density here. So you can see that present of air above it. And here's the CT equivalent, not the same case, this is slightly lower down. But you can appreciate in this supine patient, this is on a CT scanner, the density goes to the back, so the air present now is at the front. So this is also an aspergilloma with the fungus ball, mycetoma at the back here and air in front. Oh yeah, just other causes. TB obviously isn't the only cause of the cavity. Always bear in the back of your mind, like in this case, there's a fairly typical lobar looking pneumonia. We can see it bounded inferiorly by the horizontal fissure here, so that's an upper lobe pneumonia. And then a week or so later, this was the appearance. We can see a large cavity within this area. This was a Klebsiella pneumonia. Other causes, obviously, Staphylococcus, atypical mycobacteria can cavitate as well. Vasculitic causes, mixed connective tissue disease or Wegener's, and don't forget neoplasm, in particular squamous cell carcinoma, often cavitates. So later on, when it's healing, we often get this appearance of linear fibrotic bands. You see how the hilum now is pulled right up here. The hilum normally be down around this level, pulled up towards the apex on both sides, more marked on the right. This is due to the traction from the fibrotic scarring subsequent to the TB infection. You can see the vessels heading down to the lower lobes are all stretched and lengthened on both sides. Elevated bilaterally. Volume loss. You may get secondary bronchiectasis. So these patients may present with hemoptysis, which may not indicate reactivation. You can get hemoptysis from bronchiectasis or from scar carcinoma development. This sort of typical appearance, initial presentation post-primary TB with the upper lobe consolidation was diagnosed correctly, and then the subsequent films showed the progressive healing back to almost normal without any significant scarring on this one after successful treatment. Extrapulmonary disease now is a sort of always been there, but it's growing. It's more likely in immunocompromised patients, so certainly in HIV. We often get a lot of extrapulmonary manifestations of TB. It can range from gastrointestinal tract, bowel, liver, peritoneal disease. In terms of urinary system, from renal, it can involve bladder, ureters, gynae, often esophagitis, prostate or orchitis. Endocrine systems, often adrenal, but not often, but predilection for adrenal. Lymphadenitis is quite common, and we commonly see an appearance like this. Now, I haven't included any slides of ultrasound, but ultrasound is very useful in investigating particularly superficial lymph nodes like this, and you can guide a needle into that for diagnosis. You can aspirate and get culture, material for culture and sensitivity from ultrasound-guided aspiration. MSK presentations, not unusual, particularly in the spine. Pott's disease, osteomyelitis of the spine, and discitis of the spine. Often communicating or extending laterally and involving psoas muscles, so you can get a psoas abscess, which I have an example of in a minute. CNS involvement also, you can get a meningitis, or actually tuberculomas within the brain, which I'll show you in a minute as well. So just talk around a couple of cases. This is the film we saw earlier. The story was a 22-year-old Asian chap. I don't know if this was the Asian chap. No, I don't think so. Presented with abdominal pain, actually, and diarrhea, weight loss. So we do a chest X-ray. That's fair enough. And that normal. But he still had diffuse abdominal tenderness. So we had a CT, and we included the chest. And this is a nice example, this sort of fluffy, ill-defined nodularity, branching bronchovascular structures. This is what's called a tree in bud appearance. This is fairly characteristic, it's just in case you don't know what a tree in bud looks like. This time of year especially. You see the similarity, I think. This is the typical, it was often thought to be characteristic of TB. It is characteristic, but it's not pathognomonic by any stretch. This chap, lower down in the abdomen, also had this thickening of the peritoneum here. So there's this, difficult to pick up, with contrast isn't brilliant, but thickening of the peritoneum on both sides, and just a general sort of muckiness of the omentum anteriorly. This guy had bone changes and peritoneal thickening. So that was TB peritonitis with pulmonary TB. And just here's a little helpful list that I just want you to remember of other causes of tree and bud appearance. So just to remember, it's not pneumonia. Here's another patient, came also with lower abdo pain and diarrhea, low-grade pyrexia, raised CRP. Abdomen showed splenomegaly and suggested a large group of lymph nodes just below the spleen. And they thought this person probably had cancer of unknown origin. We did a CT, and indeed, spleen is slightly enlarged, 14.5 centimeters. Upper limit of normal is usually around 13. But also, when you come lower down in the abdomen, again, we see this thickening of the peritoneum, abnormal density. This should be fat density in the omentum here, and also in the mesentery. It should be dark, like the subcutaneous fat here. This is increased density and nodularity. This again is diffuse peritoneal TB. And lower down again in the pelvis, we see this loop of abnormal small bowel. Very thick walls, abnormal lumen. And this was the distal ileum, also presumably involved with TB. I think TB was cultured from the peritoneum. This different possible entry points for TB to get into the peritoneum. It's that's be hematogenous spread from the lung, but it can be direct from bowel or from a perforated lymph node, or just direct ingestion, either from coughed up sputum and swallowed, Mycobacterium bovis from unpasteurized milk, or from fallopian tubes. This case here shows a bit more fluid. Ascites here. There's enlarged lymph nodes. In this case, it's called a wet peritonitis, wet TB. There's different, it's categorized into different types, basically, based on whether there's ascites or not. If there is ascites, which is the commonest type, it's called wet. If there's no ascites, it can be dry or fibrotic. Dry just means this sort of appearance. No, I think that's it's not a classic example. There's not a lot of ascites. Dry tends more to suffer from adhesions and bowel obstruction. And the fibrotic type, you can have mass-like plaques on the peritoneum, which often can calcify. Typically, lymph nodes in TB have central necrosis, and this is a slide I put up earlier, but it just shows you, some of this is probably abscess, but the lymph node, this is probably a lymph node here, which is enlarged with peripheral enhancement, a central low density on CT, necrosis in the center. And we suspect TB, and the lymph nodes look like this, wherever they be in the abdomen or in the chest on CT. This is evidence, possibly TB involvement. Here's another case. You can see the abnormality in the lung. Here in the subcarinal region is an enlarged lymph node with this central necrotic focus. And this turned out to be TB as well. Lymph node necrosis is one from the literature. Just showing again the same appearance in the abdominal lymphadenopathy. And here's enlarged lymph nodes in the celiac axis and the porta hepatis, very large lymph nodes. And you can see there's another one there in the mesentery. They have this high density rim with necrotic, low density centrally. Fairly typical. Okay, another case. Right, this might be one for audience participation. 25-year-old man, left-sided lumbar back pain. It's amazing how many present with extrapulmonary signs and symptoms. When you do the chest x-ray, there are abnormalities in the chest. Lumbar back pain, tender over hips, no direct trauma but now affecting gait. GP sent for chest x-ray and lumbar spine, which I think is fair enough. Okay, who wants to say what they see on that chest film there? Yeah. Don't rush it once, yeah. So it's normal, is that what you think? Anybody think? Yeah. Yeah. And that was what we reported, and that's all that was reported. Important things to look for, obviously, bony involvement. Have a look, make sure you have a good look at the spine, especially in somebody like this. What are you thinking from the history here? Lumbar back pain, affecting gait, what could that be? Yeah, psoas abscess. So you can see the spine and the paravertebral soft tissues on a plain film. Make sure you look down all the way. I had a close look at this. I was hoping to say, oh look, there's a bit of a bulge there, but there isn't. Just make sure you look. Yes, I think the item on the left certainly is slightly prominent. Also, we've looked at the AP window as an important place to exclude lymphadenopathy. Be subtle. And the right parietal region. They all look normal. Okay, fine, we're happy with that. Yeah. Here's his lumbar spine now. Not quite right, is it? Anybody spot any abnormalities there? Poor projection, I agree with. You ever see? Definitely there's a scoliosis. And a muscle bulge, did you say? This one's a bit wonky, isn't it? And in fact, that vertebral body, look, you should be able to see the end plates clearly, top and bottom. You can see the end plate on the bottom. Look at the top of T12, vertebral body. It's indistinct, it's gone. Where's the pedicle? Remember to look for the pedicles as well. The pedicle on the right, can't see it there. Also, L3, no, pedicle missing. And when I was looking at this last night, there is actually a bulge in the psoas muscle there, but you can't really see it there. And also in review, I thought this SI joint was a bit abnormal looking. Anyway, I'll come back to that. Yeah, pedicle's gone. Good. And this was thought, oh, you must have Mets. So, CT was done. There's this thing in the rib, so we didn't really see that. That's probably contributing to the apparent left hilar abnormality, but it's not at the hilum at all. It's in the posterior chest wall. There's erosion of the rib and transverse process here. Whoops. Higher up, what's this? Big mass in the third rib as well. Expansile, low density. Below the carina, nodal mass there. That actually looks pretty clear. So actually, yeah, lower down can show the sections, but he had destruction of those vertebral bodies, as you pointed out, T12 and L3. T12, this is an MRI scan, stir sequence, so that is very sensitive to fluid, water and edema, so it's good for looking for pathology. This is a sagittal stir sequence through the thoracolumbar and sacral spine. T12, you can see there's destruction there, and there's a big bulge at the back which is pressing on the conus medullaris, which is just about this level, usually T12L1. The L3 vertebral body, although not destroyed, is abnormal. And look at this, there's another abscess here in the presacral with osteomyelitis of S4 or 5. So there's lots more to see. The modalities of different things. And here was the coronal section again, third image. You see around this L3, there was a lot of disc space here, but there's also communicating this large abscess which went down towards the left hip. That explains his presentation. Imaging is also very useful for guiding diagnostic aspiration or drainage. We usually don't really do much drainage of TB per se, unless it's causing pressure symptoms. It's usually enough just to get a bit out for diagnosis, and then once treatment commences, if it's sensitive, it melts away. You see how this is bone? Obviously the bone doesn't really grow back, but it does heal up by sclerosis. So let's go back to this chest x-ray then. See, the left hilum did look a little bit bulgy, but most of that is actually soft tissue. The end of this rib here is not clearly seen. Likewise, there is, in retrospect, an increased density here anteriorly behind the clavicle. If you compare with the other side, it's subtle and grey, but it's there. There was a bit more there than we actually. You can actually see the start of the scoliosis there. T12 is just about visible. Okay. This 56-year-old gentleman, I believe. Weight loss, lower back pain again, smoking. GP thought he had cancer, sent him up for chest x-ray, lumbar spine. Chest x-ray was reported as normal. Lumbar spine, not so much. So again, we can see 5432. L2 in this case is sclerotic. This looks a little bit, it's a bit sclerotic really. The pedicles are intact. Nothing much else seen there. the CT, chest, abdo, pelvis, lungs, again, but clear. But when we get down to the abdomen, we can see this destructive lesion in the L2 vertebral body and extending laterally with this soft tissue lesion extending laterally with focal areas of low density necrosis within that. And then when we look, so you can see this on the axial sections, but I think it looks nice on the coronal reformat here. You can see this big oblong fusiform abscess collection extending down the left psoas muscle towards the hip. Another case here with show the appearance of discisis on CT. We can easily, once we do the CT scan, we can reformat them in any plane because the slices these days are so thin. We can just do multiplanar reformats with the same resolution in any plane. Here we can see loss of disc space at least 2 levels, bone destruction, loss of cortex, particularly posteriorly here. This is 2-level discitis and osteomyelitis, Pott's disease. And on the soft tissue windows, we can see this soft tissue abscess in the epidural space, bulging backwards again, causing spinal canal stenosis there. And again, CT was used as a guide to that was a drain insertion. Just to look at some examples of CNS TB. These are tuberculomas. This is again, this is a post-gadolinium MRI. The posterior fossa. You can see these multiple little ring-enhancing nodules throughout the brain. And those are tuberculomas. This one is post-contrast MRI showing leptomeningeal enhancement. So this goes into the sulci. There's thickening and enhancement of the meninges, which is abnormal. This again was another case of TB meningitis. 32-year-old lady, flared up, 6 weeks cough, she had some weight loss. Chest X-ray was done, multiple small nodular deposits throughout both lungs, appearance suggests miliary TB. Patient was referred to TB clinic. I mean, you can agree there's a miliary pattern of shadowing there. So CT was done, and that showed this tree and bud, pretty much, appearance with lots of fine alveolar, little fine nodules throughout both lobes. So that was sort of taken as corroboration of some diagnosis of TB. However, the tests didn't really confirm that. It was culture negative. TB treatment was commenced. Obviously, the CT didn't show any other abnormalities at that time, just this diffuse lung pattern. Personal TB, repeat bronch, field adenocarcinoma. So this was an adenocarcinoma of unknown primary presenting with a miliary pattern of deposit. So, you know, pattern recognition is all well and good, but just remember your other causes, miliary. Typically, it's breast, thyroid is the other one that often causes that pattern. MSK involvement, we've all seen bone involvement. We just saw some spinal TB, but it can happen anywhere, particularly in the hands. This one is in the metacarpals. See just this. You can't say it's TB by the appearance alone. It could be aneurysmal bumps. This could look like that, but you wouldn't see it adjacent metacarpals and also something in there. So it's gone across the joint space there, so it's likely to be infected. Here's the MRI of that patient, and it shows much more extensive disease. You can see this involving the intrinsic muscles of the hand here. This section just slices through the dorsal aspects of these bones, which we see in pre-signal here, in the fourth, and also in the fifth, which we didn't appreciate on the plain film. So it's telling us the fifth metacarpal is also involved. Dactylitis is a similar process involving the phalanges. Sort of diffuse with some cortical destruction, diffuse lytic lesion, and a large soft tissue component there as well. So, summarize. TB is a protein manifestations on radiology, on imaging, and can be difficult diagnosis. It's important to try and get all the information together because wrong diagnosis obviously can have serious consequences. False positive, for example, you may miss cancer. False negative will leave TB untreated. Pattern recognition needs to be combined with full clinical and pathological findings. Common mimics include lung cancer, lymphoma, and sarcoid. Sarcoid can actually mimic the findings in lung, musculoskeletal, CNS, and heart TB. Radiology has a vital role to play in the diagnosis, imaging, and sampling, getting tissue for culture and sensitivity. Thank you. Any questions? I'll be happy to answer them if I can.